Good morning, ladies and gentlemen. Welcome to another episode of Monitor Your Health, the program where we educate the public on contemporary medical situations. Today, we'll be talking about emergency service in primary healthcare setting. My name is Dr. Femi Ogunremi. I'm the host today, and I have with me Dr. Pir Shah. Before Dr. Shah introduces himself, I want to paint a scenario. In Nigeria, as it stands today, there's a lot of issues around, emergency service. If somebody, for any reason, at any part of the country collapses, there's chaos, there's confusion. People do not know what to do. And possibly, we want to help these people. During the process of our, engagement with them, some people will say, pour water on them. Some will say, carry them. Some will say, put chemical, put this and put that. And there's so many things that happen in this chaos. There's no structure and there's no ambulances to call. There are some of the states in the country where we have just a bit of, structure in place, but this structure is still not effective. So we feel that it's important for us to bring, somebody with a new eye who has not seen what's going on, just tap into their experience. Dr. Pir Shah is a clinical director in West, Midlands in the UK, where he oversees a structure where we have primary healthcare engaging in emergency service. You're very much welcome to the program, Dr. Pir Shah.
Thank you. Hi, Fem.
Yeah, thank you so much. Can you introduce yourself to the audience?
Yeah, of course. Yeah, my name is Dr. Pir Shah. I'm a clinical lead for integrated urgent and emergency care services in the West Midlands. And I'm also a regional clinical advisor for NHS England for integrated for urgent and emergency care. So I work with the Nine, which is an ambulance service, and also with something called a 111 service, which is a clinical advice service. And we align all of this up with primary care, and we also align it up with out of hours and urgent care systems, which I'll explain later.
Right, thank you so much. I know that what we're going to discuss today might look a little bit, strange to you, but that's why we want you in the next 20 minutes to see what we can do. What is a structure of an emergency care service that is effective? What would you say?
Right. So I would say one of the great things is you've got to use technology. And I think if you use technology, you've got a good, I would say that's a good place to start. But the structure needs to be, there was a point originally where the structure was you call for an ambulance and you simply get an ambulance. And effectively, it's just becomes a delivery service. You come pick up the patient, take him to hospital. But I think things have really moved on from there. You don't really want just somebody who picks up a patient and delivers him to hospital. What you want is, before that, a clinical conversation, a conversation with a clinician or somebody who understands your clinical problem. That 50% of this can be managed over the phone. And then what needs to go into hospital, what needs to be managed, then an ambulance come out efficiently and manage that patient effectively. What you don't want is actually a patient that is laying on the floor to be managed, to be moved by somebody who doesn't understand the problem of that patient, because that adds a lot of clinical risk to it. So what you've got to be really clever about is actually having quite a clean service of telephony. So somebody calls a number, somebody picks up the phone, they then talk to what we call call handlers here. They have a clinical pathway conversation. So a clinical conversation where the patient or the person who's seeing this patient explains what they're concerned about. And that person on the other side of that phone then decides on what that patient best needs. Do they need help now? And if they do, then they get an ambulance out straight away. But the ambulance itself needs to be reasonably well trained to then manage that patient. The people within the ambulance, the paramedics in this case, in the UK are really well trained. They do a 3-year degree. It's now a degree qualification, so they can then manage this patient safely. Because you need to know if it's a medical problem or if it's actually a traumatic problem, and therefore that patient gets managed appropriately and gets sent to A&E, for example, but in the right, correct space, and that's very important. So you need to really link all of this up. So you need to make sure that there's a telephone system that's available to ambulance services that can then filter these calls. And then you need an ambulance service that's clinically driven, and therefore you have clinicians working with an ambulance service. And in many cases, what you also need is a primary care service that works with it. So the opportunity you have with technology, which is you can connect all these dots up. You can connect an ambulance service to the population. You can connect them to a hospital. You can connect them to primary care, which is really important. You can then connect them to community care. So that's the massive advantage you've got with technology. So if you use technology in the right way, then actually carries a lot of value and actually saves you a lot of heartache later on.
Right. Thank you so much. I think for some reason I have to okay, so I'm speaking on an okay, sorry about that. So for some reason, yeah, we have to have a switch from one system to the other, which we have done, I hope. So thank you so much for explaining that. And then now the structure we run in the UK is very seamless. Now we are in Nigeria where things does not work absolutely the same way. We have challenges with so many things. There are bottlenecks from the point of incidence to the point of delivery and things. And the technology, yes, we have basic technology that works. The telephone works, the mobile phone works and things. But what we have not been able to do is to be able to orchestrate this, this technology and put everything together, and for us to deliver this, that seamless service. The way it works here now is somebody collapses, for instance, like I was painting during the course because of my initial commentary. Somebody collapses, you do not know what to do. There's no ambulance service. Well, we have this few ambulance service that works, but there are bottlenecks also when you look at, the road network system. You could have a place where there's a block and people do not even allow ambulances to pass sometimes, So these are some great challenges that we have in our system. And I'm looking, using my eye and what I see, or what I still see in England, seeing how can we, pick bits and pieces from here and there to integrate into this chaotic environment, and then put the structure in place. So what do you think, based on this chaos that literally try to explain in a very fancy way to you? What do you think we should be doing?
Right. So if you think of if we sort of simplify this whole process, and I think simple is always better, because if something's quite linear, it works a lot better. So if you think of it that you need a call center to take these calls, that's your starting point. If you then have a call center that can take these calls and then manage that problem, then, as I said, majority of them can be managed over the phone in that call center. And that call center you can have clinicians in that call center taking those calls. You can actually have primary care taking those calls in that call center. So if you have a call handler and an algorithm that you can, a piece of software effectively, that then you can tick box through a clinical problem. So a clinical pathway, that's an algorithm, with a call handler that's trained. Then that's your starting point. Then behind that, you can have clinicians sitting in the background, and they can be sitting at home, but they can take that call from the call handler, and they're really managing that call over the phone if that's what's needed. So that then takes away part of this problem of your bottleneck of, if there's a problem of trying to get to the patient. But also behind that call center, you do need a set of ambulances that are ready to go when there's a patient that needs an ambulance. But your initial point is getting a call center that functions and takes these calls, and then having the services sitting behind it, which is primary care, secondary care, which are hospitals, and ambulances, and even community. So you can basically align all of those up. So what you basically have to develop is a database that if there's a call handler and they've got a medical problem and they want a certain clinician, you can set up your coding system so that it can give that call handler a list of things that this patient may need. So it may need a GP, it may need a community healthcare, or it may actually need an ambulance, and it gives you that profile. And then they can just literally pick what comes up first in that list. So that's so the call center is pivotal in terms of managing this, because that then allows for this process to begin. And sitting behind that, you can sit anything behind that, really. Does that help?
Thank you so
give
much.
You a bit of an idea?
Yeah, it does, because I know there are, legal states, the state where I'm in, they have a call, it's a system where people phone in, and then people, sit at the back there to pick calls. It's not something I'm not privy to what they do in there, because I've not actually gone to assess this, process. But I know there's this basic process that is up and running. It's been running for some time, but in terms of how it integrates, I don't know. And I know for sure that there are ambulances aligned to that, but there are only a few of them. And then the issue now is, I look at a situation based on our situation in the country. I look at a situation where, where we can actually use our primary health care more than the secondary care, because with the logistics issue, the secondary care is, they're scattered and they're far from places. And the thing again is our secondary care works in a way that you can see this big hospital where that's the only place you have this neurosurgeon standing. And then you might have another one that's the one you can see more of, if somebody has an emergency endocrinology, that's where you can find them. So you can find somebody collapsing, needing, trauma involvement, and they collapse close to the hospital that is actually not rendering that service. Or they do render that, or another scenario is the patient might collapse somewhere close to an hospital where they can actually help him. But instead of them, the ambulance taking these people, this is what I've seen has happened before, taking these people into that hospital, they take this patient to another hospital far away, in between this, terrible road network system. They get there and they say, no, you have to go back to that place. So you lose
this time,
like 3 hours more in between. And that impacts on the delivery as well. So my own inclination is looking at our system, comparing to what operates in England, whether we can build a system whereby people use more of primary care than secondary care. So the primary care system is able to offer a layer of emergency care, and then they're easily accessible. You understand? And then, and then from there, they can then move this patient, if they need to be escalated, to another system. And I thought, you have been in a position where you are, you oversee an integrated service whereby you interface between the primary care and secondary care. How have you been able to integrate maybe a kind of relationship between these two systems?
So obviously, you know how primary care works here. Primary care doesn't necessarily do much, or doesn't do much emergency. It's understandable because the way it's set up here, because we do have quite a robust secondary care system here. So in the UK, obviously with primary care, the way we've made it work now, and that's because a GP knows their patient well. So therefore, if that patient calls the 111 service, which is like an urgent service, or a 999 service, and they don't actually need an ambulance, and actually they need a GP, then you're able to then book into the GP. You can actually book a slot into the GP's practice for that patient to be seen or discussed or reviewed by that GP. So that's very feasible now. So that patient, and what they've developed is you can actually do that into an A&E. So if a patient does call, or somebody calls for the patient and they don't need an ambulance after that call, that call center conversation, then they need, say, an A&E department, but they don't need an ambulance, then they can book them into an A&E. Now, what I would say in your case, I would say you take a step back, and the first thing you need to do is work out what services are there, what's actually physically there at the moment, what community systems are already present, what GPs are available. So you need to really map out what's already there. and then get that primary care and community care involved in this process. So if the primary care on your patch are keen, then absolutely, because the bottlenecks you've got, it may well be that what you need is the call handler calling a GP and saying there's a patient around the corner from you and they're collapsing, we need you there now. So that's all feasible, but you need to get primary care on board to do that, because again, and you may need to offer them, in a lot of cases you don't, but especially in the environments you work in, primary care works differently. It does a lot more acute work than you would in UK. So therefore, they may be better placed to manage these patients. And also, you can offer them training if they need training. But the bottom line is, you're quite right. If the choice is that patient doesn't really stand a chance waiting for an ambulance, and the ambulance takes hours to get there, and actually you achieve very little in that process, then it may be that it's prudent and appropriate for a primary care clinician to turn up and manage that patient as best as they can, because that's an environment that patient, that primary care service sits in. So that's very feasible, but you need to then get primary care and community care on board and work as part of a team. So you're not talking about then primary care and secondary care and all of the systems there. You're talking about integrated health service. You're talking about everyone working on one thing. The patient's the focus, and everything else becomes very secondary. And I think if you do that, that's very feasible. But you've got to really get everyone on board, and you will get colleagues who will be very keen to do this. And actually, if they do this, it'll work. Because what choices do you have? You can't wait for an ambulance 3 or 4 hours, and then have an issue of trying to get through to them. It just isn't. So if you can get a GP to them in about 30 minutes or 15 or 20 minutes, because they're around the corner, and you simply call them and say there's a patient, laying on the floor around the corner from where you are, they'll be there. And I think that it's more of a logistical issue. So very feasible. You just got to get primary care on board. But we both know with technology, this is all very feasible. Even with simple telephony, you've got to get that central bit, which is that call center element in. Now, the other way of doing that there's an app. So in the UK, there's an app. So you go online. It's called NHS 111 online, and you go into the app, and you basically go through a clinical question and answering session, and they then spit out a choice, and the choice is, yes, you can contact a clinician, and they can, and that's so a whole gamut what you can offer, depending on how you want to set the algorithm up. You can offer primary care. You can actually have a number of a clinician there that they can call and say, look, can you come round? X, Y, and Z isn't well. So that's all very feasible. So I think yes. So it may be in your case, you don't have that. You have the call center, but you have those GPs. You have a really good system of understanding of what services are available in that community, and that's feasible. In the UK, we call that something. We call it the DOS. The DOS is, I'm sort of simplifying this, but it's like a database of all the services that are available throughout the day, 24/7. They're open, what time they close, and the detailed contacts and what they offer. So that's the kind of thing you want to develop is a sort of database that offers you that information that can be used by the call center.
Brilliant. So in fact, you just answered the question was going to be my next question, but you just answered in the middle of your discussion, because I was looking like, okay, fine. It's possible to put a structure in place where people can call, they can, but how do we know what services are available? How being able to, so mere using a form of app or something like that can tell us, this is the condition that you can send into this place, or what you can bring into this area.
Great.
That will probably help in our situation. So now looking at this, I'm just going to be a little bit more into clinical aspect of our work now. If you look at what operates in the UK, obviously the conditions that we have there is a bit different in a way. When we talk about trauma is trauma anywhere. So somebody's got head injury, it's going to be head injury everywhere, and it's going to be the same. But if somebody has, say, severe temperature, very high temperature, for instance, in the UK, I'll be thinking sepsis. The first thing that will come to my mind here will be malaria before I then start thinking about sepsis and things. So I'm looking at what's your view about how one can stratify, conditions like this in an environment. I mean, in England, the stratification or the path that you've taken to know this is what if it's medical emergency, there are certain things that we have algorithm and things like that you take you down there. How have you been able to put such together? Because I'm thinking like it might be something that we'll be able to do for the system around here.
Okay. So look, there's a whole gamut of algorithms out. There's companies throughout the world that sell off our clinical algorithms. So, in the UK, we have one of the ones that we use that's used quite heavily is called Pathways, and it works quite well. But remember, algorithms are risk averse, which means that algorithms are used by non-clinicians. They're used by trained call handlers. Clinicians don't tend to use algorithms. They actually look at the clinical problem, and using their knowledge and understanding and experience, they then decide what's best for that patient. But the number of calls, so because the number of calls you're going to get in that call center, so to give you an idea of the number of calls for a population about 5-6 million people, for a population of 5-6 million people, you're going to get just I'm not even talking the emergency numbers, we're talking about urgent calls, and about 5,000-6,000 of urgent calls a day, and that's just for urgent. That's not emergency calls. If you double up, that's your emergency calls. So you're talking about 10,000 calls a day, at least bare minimum, and therefore no one has that number of clinicians to manage 10,000 calls a day. So you need to then have a clinical algorithm at the front end that's designed for your region. So when it triggers a temperature, it doesn't just trigger sepsis, it triggers, it offers that nuance. So your algorithm for the UK for a certain population will be different to the algorithms you're going to have on your patch. And therefore, so in some cases what they do, so if there's a query by a call handler and they're not really sure, that then effectively pulls out that case and it gets handed to a GP, and the GP then takes that call, and they then have that conversation, and they can then differentiate what's going on with the patient in a lot more detail. And what you're seeing is those cases are closed much more effectively, managed much more effectively. But the reality of the situation is you can't do that with every call. You've got to filter out the calls that are necessary for clinicians to take on. So the way to answer your question is, one, you can tweak your algorithm to suit your region, and therefore it can differentiate. So if you want it to differentiate for malaria, then you have a bunch of questions it asks, and then it spits it out as, I think this is more likely to be this. Now, if you want the call handler to make that decision. Now, if you don't want the call handler to make that decision, you can still keep the algorithm, but actually throw that case out to a GP. Because remember, not every call that you're going to get is going to be a raised temperature.
Of course.
You're going to have a whole gamut of calls, and these is a nucleus of calls, and then the GP can then manage that call over the phone, and they can do that from home.
Yeah.
So with technology, you don't have to be sitting anywhere. You can do that from home.
Sure.
So that's all feasible, but you've got two possibilities. Get an algorithm that suits that actually reflects your region and the medical problems and the issues in your region, which is very feasible. That's what a lot of these algorithms do. They'll be designed around what your needs are, and then you have some of these cases based on that algorithm that are allowed to then go to what we call a speak to a clinician, and then a clinician talks to if needed. But it just means they're not talking to 10,000 calls a day. They're doing what's needed, or more acute or more complex calls.
Thank you so much, Pierre. The other thing I think is important for us to know is, maybe on a sort of point, number by number, maybe we should just go through, if we're to set up, let's say, a system which will run, sort of the thing that we're discussing, can we just blow by blow just list and then say, okay, we need to have this in place, we have this in place, we have this in place, while we're rounding up this program, because 30 minutes almost is fast spent now. But I'm wondering if we can just have a look at what are the things that we need to put in place, looking at mean, of course, at the background, we're thinking about this chaos that is happening in our own health system here, because our health system is a bit chaotic. Our node is all over the place, you know. So
Yes.
can you just from your own vast
So
experience?
number
Yes.
one, you need to develop a database
Okay.
of clinical information for your region or for your patch. Okay.
Yeah.
That tells you what's on, when it's on, and when it's available. And that's just not primary care. You can do community and also secondary care. And even secondary care, like you said, if some of the hospitals only do, if some of the hospitals just do stroke and some hospitals don't do stroke, then they need to tell you what time that they switch on their stroke service and what time they switch it off. So that information goes into this database. So the database is pivotal for things to work. And that's, you develop an initial one and then you work on it. You build it as it goes along. So that's one. You need a telephony system that works. Okay, so you need a robust telephony system. You then need an algorithm to develop. Okay. You then need to train your call handlers. And that's all. That's not difficult. It just takes a bit of work, but that's not difficult. Okay. And those are the basic fundamentals you need. You then need to talk to your community and primary care services and actually talk to all the healthcare services. Say, look, we can actually offer the population a phenomenal healthcare service. But what it requires is for all of us to be talking. If we talk, our patients are safe. If we work collaboratively, our patients are managed the way they deserve to be managed. Okay, and I think that's the pitch to all my colleagues. That's a pitch to all of us. That we know our job is to manage our patients to the best of our ability, and we need to really work together to do that. So that collaboration is essential. So those are the basic 4 or 5 fundamentals you need to start with. And an ambulance is one element of that. An ambulance is one element of that.
Ambulances, yes. I was going to mention that. Thank you so much, Piers, for this insightful discussion into what operates over there in the UK. And obviously, to my colleagues, I know that we had a bit of technical issues. I can't even go on Facebook as it stands now because I'm using my mobile. I hope that my colleague who is at the back end is looking at it. But I will go and look at any comments, questions, or things that's been posted, and I'm going to answer those ones. I know that a lot of people want to ask questions today, but unfortunately, because of the issue today, we couldn't get them on. Now, I'm looking at something, and I hope you will just say yes, you'll be in for it. From what we've had today, possibly because we haven't had other colleagues contributing, I found it difficult to tap deeply into the amount of the wealth of knowledge that you have in there. And I think I would like a situation where I will pull maybe 2 or 3 of my colleagues who practice, where we can pull together, and then we can then discuss looking at the issues that we have on ground, and then looking at from your own view, whether we can just rub minds together and see whether there's something better than what I've done today that we can pull from such a discussion like this. I hope you say yes to that.
I'm happy to help, Femi. I think in all honesty, I've told you this before. I think what you're doing is quite phenomenal, and I think that anything I can do to help you, I would happily help you. I think all human beings deserve the best healthcare service possible, and I think it's essential that we as clinicians recognize that, and it's our job to do the best we can. So I think, Jemima, you're more than happy to help in this case. Not a problem.
Thank you so much. So after the program, I'm going to come to you, and we're going to see how we're going to put something together for this. So while at this point in time now, we're getting to the end of this program, where I just want to thank you for your time. Thank you for always being there each time I come to you, right from the foundation year days. Just I need to let the cat out of the bag for now. Myself and Piers were together in Wolverhampton during our foundation year 2 training, and that's where we clicked, and then we've been together since then, and it's been a fantastic guy. Thank you so much for giving us this opportunity today, and I look forward to the next one that we're going to have. And to the viewers, thank you so much for joining us today. Sorry if you haven't been able to ask your questions. Obviously, if you put your question below, I will take them personally and I would answer them.
And once I can't answer and I need Dr. Pierce to, to answer, I will forward to him, or I will draw him into the discussion, and he'll be able to advise us on things like that. Now, I need to make it clear here that, emergency service is at the core, at the center of what we do. How we handle it determines what happens in the end, because we look at, the initial care that we've given. That would determine the quality of life sometimes of this person that, we're dealing with. For Nigerians, I know the ambulance service is not robust. I know that the emergency service is not robust, but there are basic things that we need to know about, care for somebody who is in collapse state or who is in a serious trauma situation. Do not rush to pick these people. Sometimes during the course of us going to rough handle and carry them with the genuine mind to want to help, we kill a lot of people. We are just a system where we have our bones giving us our shapes and then protecting certain things in our body. For example, our spinal cord is a round bone that protects the spinal cord. The spine, if you move this thing wrongly, at some point you can just cut and break the spinal cord and the person can paralyze or stop breathing right there. So a lot of the time when somebody collapses, we rush to help. Genuinely, we wanted to help, and it's okay to help, but that help that you offer might be what takes somebody's life away. Now, there are trainings that you can do, things that we can get online or have some training, basic training. If it connects with this channel, we will be doing some, free pro bono training for people to understand system, things you need to do when somebody collapses or things like that. And then you can get yourself, equipped for if that happens. How do you help your relative? How do you help your friend? How do you help your colleagues? Because you don't know who it's going to happen to. And I've seen situations where people collapse in this country and people start pouring water, they start shouting, kicking them, beating them until they pass on. Mere CPR, putting your chest on the chest and then do the right effective chest compression, you can keep this person alive until they get to the doctor. We'll talk about this for another time. And if you're interested in being certified to do this, also, follow us, or you let us know from here, or go on our website, monitorhealthcare.com, where you can see various trainings that we do in this space. Thank you so much for joining today, and I look forward to meeting you again next week, where we'll be talking about another topic. Have a nice day, and bye-bye.